This episode is brought to you by Neox Marketing. Are you looking to upgrade your business? Do you want to develop your marketing skills but have no idea where to start? Boy, do I have a deal for you. With promo code SmackTalk, you can get not 25, not 50, not 60, 80% off their marketing ebook. That comes to a total of $2. Yeah, this ebook has everything, okay? It took a year to make. It's simple to use, so you can get started ASAP. So Johnny, you're saying you can get an entire ebook, a step-by-step guide for scaling my business for only $2? That's exactly what I'm saying. With promo code SmackTalk, you can use it at checkout or click the link in the description. That is promo code SmackTalk for 80% off your purchase. SmackTalk. Tell a friend to tell a friend and enjoy the episode. Peace.
One high fly ball, deep right field, backing up Eaton, and that one is out of here.
No side.
He crushed it, and the Red Sox have taken the lead.
Bitch, put some respect on my name. Hey. When you speak on me, you speak on the game.
Guys, welcome back to Smack Talk. Today's guest is not only a clinical psychologist and mental health expert, but also an eating disorder educator. Ladies and gentlemen, Dr. Meagan Gallagher.
Hello.
Welcome. So before we start, okay, we get into the deep end. Who is Dr. Meagan Gallagher?
So like you said, I'm a clinical psychologist. I work in Ottawa, but see clients all across Ontario virtually at this point. I did my PhD at the University of Ottawa, but I was born and grew up in Thunder Bay, Ontario. So also having that experience of living somewhere that's much smaller and where health resources are a whole lot different for folks. Mm-hmm. I am a snowboarder, a procrastinator, an aunt of two little people who are my favorites in the world. A partner, someone with ADHD, someone with my own experience of eating disorder recovery as a young kid. I kind of lucked out and things sort of hit early. I'm also the child of a Greek, old school nurse mom, which was helpful for me in getting what I needed.
Culture-wise, I guess?
Yeah, and I think also interesting culturally, right? So there's the cultural piece around kind of like food and food being kind of love and a thing to not really be moderating too much. So also, this kind of family culture of a lot of seeing food as really good things and celebrating food, family dinners and that kind of stuff.
Wow.
And then, mom's cultural background, mom's, professional expertise.
Yeah.
That all those things for me were very helpful.
So that's why you are so interested in eating disorders.
Yeah.
So who do you typically work with?
I work with adolescents, and I typically see older adolescents, so kids about 16 and up.
Okay.
But I also see a lot of individual adult clients, as well as with couples and families. I also have a particular interest of working with military personnel, so active military and veterans as well.
In what sense do you work with military personnel?
I do a lot of assessments for CF Ottawa, but I also do individual and couples therapy with military personnel. So a lot of that is PTSD referrals, as you might imagine.
Yes, of course.
But there's a really, really big overlap in terms of folks experiencing disruptions in eating behaviors, whether that's full-blown eating disorders or just eating stuff that's kind of gone awry.
Do you think social media has an impact on that nowadays?
I think definitely, but I think in maybe a couple different ways. That in some ways it's opened up and there's some really good information out there. So we don't want to just kind of poo-poo the whole thing. But there's also that we're seeing, I think it's often something that comes up, hey, is social media causing eating disorders? And we're like, well, eating disorders were alive and well.
Absolutely.
A long time before social media hit or before we were all such high consumers of it. But we do know that high consumption, and especially with younger folks, can really shape their ideas about, their own bodies, but also just what's normal about food and body. And some of the kind of tricky stuff, a lot of the, if you've ever seen any of the more kind of thinspo kind of stuff that's out there, our brains can generally differentiate that as being something that is quite extreme. And for someone who's not in their own eating disorder or not kind of on the cusp, we'd go ooh, doesn't look like somewhere I want to go. The more Fitspo stuff, though, that is sort of less obvious, we know that's harder for even, healthy adults to differentiate. So that can really have some pretty big impacts on, how people internalize the thin ideal or whatever sort of that body or appearance ideal is.
Well, you're talking about, like, what are the eating disorders? Like, what are the different types of eating disorders? Can you get closer to the mic? Your voice is amazing. We want to capture it.
Yeah. So when we think of the eating disorder, so we work from a clinical perspective in terms of our diagnostic manual. It's now the chapter that looks at eating and feeding disorders.
Okay.
Generally, what we hear of most would be anorexia nervosa, bulimia nervosa, binge eating disorder, as well as like otherwise specified eating disorders. And I think that's a really important category to talk about because humans are messy.
Yeah.
And our diagnostic systems put things into categories for good reason, not to kind of take the human factor out of things, but for research, for treatment planning, and to kind of give some variability about where people's clinical presentations might hang out together. But that otherwise specified, or what used to be kind of looked at as sort of like a less than or kind of a random grab bag of things, is really saying these are folks with a legitimate clinical diagnosis whose symptom patterns just don't happen to fit these other categories. And soapbox moment, one of the kind of things we can specify within that category is atypical anorexia.
Okay.
Which I think a lot of folks who work in the field or a lot of individuals who've maybe had that diagnosis given go like, well, what does that mean? Does that mean like I'm not, I've had a number of people sort of say, so does that mean I'm anorexic but I'm not doing a good enough job? It's like, no, not at all. And
So
really,
there's a lot of generalization.
there is, and I think if anyone kind of goes like, okay, command of the English language knows what the word typical means, we'd be thinking, okay, generally someone with this diagnosis, is presenting this way. The really tricky part with the atypical anorexia is that usually means someone is not meeting a weight cutoff. And the really backwards part is most people with a diagnosis of an eating disorder, or an eating disorder, even anorexia specifically, won't be meeting that. So we're saying this is atypical, but it's also the biggest group of these folks.
Wow. And like, what is the eating disorder that you commonly see like the most often? Like, what is one that always comes back to you?
I work a lot with folks with binging and purging cycles, and that could be people who have a diagnosis of anorexia or of bulimia nervosa or somewhere in between. We also know that people move a lot between categories over the lifespan, whether that's being in treatment, something's not being treated, or even kind of things coming back. Also, a lot of folks who have binge eating disorder, and that was actually where my dissertation study was a treatment of binge eating disorder in group therapy, and it's only really pulled out to be its own full diagnosis in our most recent volumes of our diagnostic manuals, which is really interesting because rates of binge eating disorder are, I think it's about kind of 3 to 4 times higher than anorexia or bulimia.
What causes binge eating?
So binge eating in of itself, usually kind of 3 triggers. The first and often the easiest to kind of get at is, are people not eating enough during the day? We often find people kind of saying, my binges, I don't know what's going on. I'm heavy air quotes for anyone listening.
Yeah, no worries.
Good during the day.
Yeah.
And then I don't know what happens. I lose it. I lose control. I'm binging at night. It feels out of control. And if it's dietary restriction, or that your body is not getting enough or isn't getting enough of like important nutrients, our bodies are on our side. And that doesn't mean they're always following the plan that we've come up with in our brain. So your body will pull for more. If that's saying, okay, I do get home and I have supper and my body then knows, okay, it's time we can eat, I can get some food, it is going to keep pushing. And not because it's not on your side, but because it actually is and wants you to survive. So factor 1 that we're always looking at is like, what does nutrition look like during the day? Are you nourished? Are you getting enough? The second is, for some folks, it's habitual. Meaning like we have formed a habit of on Thursday night, I go pick up this takeout, it's become my routine, and I have this experience that feels like a binge. And important to think, when we say binge in a clinical standpoint, we're not saying I broke a diet rule, or I had a kind of second serving, or family meal, I felt kind of full. We're saying this is really a large amount of food in a discrete period of time, and things do really feel out of control. Like people say, someone would have to rip this out of my hands. I really feel like I'm in it. People almost feel kind of like zoned out in a trance, and that there's a lot of guilt and shame that happens afterwards.
Wow. Would body dysmorphia be considered an eating disorder?
Body dysmorphia often does happen for folks who are experiencing eating disorders.
Okay, but it is not itself a eating disorder?
Yeah, a diagnosis of body dysmorphic disorder would actually fall under the category of more obsessive-compulsive related disorders.
Okay.
So we see a lot of overlap with OCD and anorexia specifically, where we know folks who may experience one may have kind of more of those kind of obsessive-compulsive sort of traits, and then with body dysmorphic disorder falling under there. Just going back to that piece around binging, the third part that we know actually pushes binges to happen for people is more around emotion regulation. And that's the part that is most common. That idea of how do we actually work with and cope with and understand our emotions is a big factor.
We have a hard time understanding our emotions, especially nowadays. A lot of people are surrounded by dopamine, a lot of dopamine. So, and plus, indulging on food too can trigger a lot of, your dopamine receptors, of course. But yeah, we are surrounded by a lot of, examples of, oh, don't worry about it, eat that. But it can be detrimental to you. Absolutely.
Yeah, and we know this from the rats in the cage psychology studies of we're not that much different, especially when we're feeling stressed or down than the mice in the hit the lever for drugs versus food kind of studies. Yeah. And it's a quick fix. It's a big reaction, and it's something that our body wants. And it's also, if we're saying, hey, every time I'm feeling low or feeling stressed and I want that dopamine, I'm binge eating because I'm not really getting at what's going on underneath.
It becomes a coping mechanism of some sort.
Yeah. And I think that's a really important thing. I mean, I hear so often from clients of I don't know why I do this. Everyone around me saying why can't you just follow a meal plan? If people are really heavily restricted and underweight, why can't you just eat? You know how to do this. I've seen you do this. Yeah. And it is really complicated. And I think to get away from the idea of understanding eating disorders as just about body and food, they are way, way, way more complex. And that's why it's, I think, so easy for people themselves to judge themselves harshly, and, loved ones and support systems to really not get what's going on and feel a sense of kind of helplessness and frustration.
So how do you help those individuals navigate their relationship with food?
I think starting in looking at really what is their relationship with food specifically. Okay. Because even if we said, we took 100 people from each diagnostic category and said, what is your relationship with food? They may have really, really different answers. We know that underlying, there are, genetic, neurobiological pieces that set the stage for eating disorders. People have their own personal history, background factors, sometimes like trauma, sometimes for people who have had periods of food insecurity, whether that's where they lived, poverty, access to food.
Their environment, yeah.
Yeah, those environmental factors. So we're saying there are a lot of things that come together to really have these things come to life. So my first step is always explain it to me. In your words, how do you understand what's going on? What has your relationship with food been like lifelong? Growing up, what kind of messages were you given? What kind of rules do you hold now? I also always want to know, how is this working? And not in the Dr. Phil, sarcastic, has that going for you kind of way. Legitimately, right? Mm-hmm. We don't do things on repeat that aren't giving us something. And you mentioned, right, that dopamine hit. So when it comes from binge eating, yeah, there is that dopamine hit. If we think of someone else who may have kind of compensation or purging symptoms after a binge, there is that tension release. Now, what the eating disorder won't tell people is, that's followed by pretty harsh consequences, psychologically, physiologically, perhaps. Even if we think, when people are really restricting, how is that working in terms of getting you through the day? That may be saying, actually, I am having pretty crushing depression, anxiety. I have stuff from PTSD coming up. Well, when we are in more of a starvation mode, that represses a lot of our intense emotions. And so part of knowing, hey, why is this working is really important for treatment planning, not only so we as professionals can know what in kind of order of operations do we want to do, but also so we can give our clients the, I think, best info about here's what to expect. Psychologists tend to be really big informed consent nerds. And I think this is part of it, to say, hey, we're going to regulate your eating, or we're going to support you in getting kind of that your weight back to kind of that healthy sort of set point range for you. All good, right?
Yeah.
And someone in their family might be saying like, yes, awesome. And we get there and they go, wow, I'm starting to have flashbacks. Or my emotions are feeling now really out of control and I don't know what to do with that. That's not somewhere that I want my client to be landing and thinking like, well, am I doing it wrong? Right? We're saying that very well could happen, but like, let's have that conversation up front.
Do you recommend diets, or you just try to find the best relationship for food that you can find with the client? Like, are you allowed to recommend diets, or like, what do you usually do?
Well, I'm a big believer in body autonomy in all ways and for all people. So if someone is saying, hey, I'm dieting, I'm pursuing intentional weight loss, and
that's what I meant.
I'm not going to be the clinician who says, well, then I can't work with you. I don't get to kind of decide and tell people what to do.
Absolutely.
In terms of prescribing intentional weight loss or any specific diet, especially if I'm working with someone with an eating disorder, it's really, really unethical. Like, one, we know generally diets long-term work for about 5% of people. And we also know that kind of a diet-based or a weight-focused approach it's kind of playing with fire, because it's really going to reinforce a lot of what the eating disorder is saying.
Wow. What's your opinion on fasting?
Well, I think some people may do it for religious reasons. Some people may do it for medical reasons. Some people may say, hey, I've tried this out. I don't have, any history of eating or body image concerns, and my energy is okay. So I'd say, like, do you? Like, that's okay. I would be like in a murderous rage in about like an hour after waking up. So
you're not the only one, doctor.
that is not going to be where my brain and body are happy. But at the same time, people's bodies are different. So the idea of, that there is one way for us to eat as people, whether that's what makes up your kind of your nutritional plan. I always think back, I was a major lover of like zoo shows and animal shows as a kid. Yeah. So when I think diet, I'm always thinking of like, what different animals were being fed. So what makes up your diet specifically might look a lot different than mine, right? Not
everybody's a lion.
No. And as people, though, we're also kind of not koalas or panda bears who are one-note eaters. So we are built for more diverse intake. And if people are following, vegetarianism, veganism, whatever it is, for reasons that are ethics-based for them, beliefs-based, or just when they go, this is where my body feels happy and healthy, and my sleep is good, my energy is good, I can focus, I can do everything, and it's not getting in the way of my day-to-day life.
So be it.
Great. You found something that works for your body. And I think when we're really coming from a place of body respect and a non-diet kind of centric approach with that, we're saying, I'm also open to when my body tells me it needs something different. And that may be in times of stress, in illness, different kind of life stages, hormonal changes are different for people. So if we said, what's happy for my body when I'm 20, I can tell you is not the same thing that my body is needing at 43. Like it's just different, right? The same way maybe our activity schedules, our sleep schedules, and all those kinds of things change.
But we, as humans, we adapt. We adapt, and we are all different. And you're right. There is no one size fits all, especially in diet. Like, of course, like if I thrive on a carnivore diet, does not mean that the person beside me will thrive. They can have it can be completely negative towards their body, of course. What are common misconceptions or stereotypes surrounding eating disorders?
How much time do you have?
Yeah. Hey, we have time.
So I think the biggest one is that it's a look, that you can look at someone and say, like, you have an eating disorder or you don't. And a lot of this comes from sometimes what's referred to as like a swag myth. So the single or the skinny, white, affluent girl. And if you happen to be that person and you happen to be seen by your physician or people in your life notice, oof, you look like someone who we might think has an eating disorder. And that's, when I'm doing training, even with counselors, with family health teams, that's often an exercise that I do with them, is saying, you have a brand new referral. The only thing you really have about your new patient is, concerns about eating, or like that we're looking at an eating disorder diagnosis. You're walking out of the waiting room, who do you see? And so often, even really experienced folks kind of squirm in their chairs and go like, I know this isn't what I'm supposed to say, but this is what comes to mind. It's like, well, yeah, and that's no one's fault, right? There's been a lot of that pushed in the media, and even a lot of the research and stuff that we have on eating disorder assessment and treatment comes from typically straight women and straight white women. And so we're saying like that needs to change in and of itself to have more diverse and more inclusive views of how these things present and how we actually approach them.
So how could we do that? Talk about it?
Yeah. And I think that's the other thing, right? That sometimes in terms of those myths that like, well, if people are experiencing an eating disorder, they're really going to be showing off their body, but this is going to be something that they're kind of leading with. And like, actually, eating disorders really do kind of thrive more like in private. People actually often have a lot of guilt and shame about what's going on for them.
So when the doors are closed, when you're alone, that's when you're like, okay, like I do not like what I'm seeing.
And so the talk about it is sort of saying like, can we get comfortable talking, with our own support systems about, hey, when am I struggling? When am I noticing I'm having more concerns about my body, or even beyond that, to be able to talk about like when we're just having a hard time, so we don't have to take it out on our bodies and go that route. I think also from the medical or healthcare side of things, we actually know from a lot of the research is that folks in kind of, again, real heavy air quotes, because there are a lot of problems with things like the body mass index.
Yeah.
But if someone's coming into a doctor's appointment and they fall into kind of a normal to overweight category, they're a lot less likely to be asked about eating disorders. Someone in a larger body, someone may go like, well, prescribing weight loss. Well, that's really, really tricky. Like we've already talked about, like that may really be entrenching a lot of really, really problematic stuff that's going on. And so to be thinking, can we standardize things? So we're asking all clients, what is your relationship with food like? What's a general day of eating look like for you? And how are you feeling with that? Because that also feeds into a myth I think that clients have themselves of thinking like, well, I don't look like someone who's very thin or who's emaciated, so this wouldn't be something for me to bring up. We've certainly had, more clients than I can count on my hands come back and say like, I tried to talk to my doctor about this, and they said like, well, you look okay. We're saying, well, yes, but that may be true. And even for some people, we're saying, actually, their blood work, their labs look totally fine. And we've rendered a diagnosis of an eating disorder in a pretty severe range. Our bodies can do really cool things. So sometimes they can go through a lot, and our blood work can look normal. Outwardly, they can kind of look normal until they don't.
What are the red flags?
I think if you see, especially like really quick changes in, rapid weight loss in somebody, or even just big changes in terms of like eating behaviors. All of a sudden, are we cutting out major food groups? Is there a lot more preoccupation about like, I can't eat this, I can't eat that? Provided they haven't been giving sort of like a medical diagnosis of like, actually you have an allergy, or you, for other health reasons, really need to be changing this stuff up. But those changes from like, we know the people in our lives, if there's something that dramatically changes, if people are becoming a lot more maybe kind of withdrawn, I don't want to go places, I don't want to see people, a lot more concern about their body, even body checking behaviors, someone spending like a lot more time in the mirror. We need to kind of go get that that smart scale and have it like middle of the bathroom and be using it every day. We want to really say, well, one, if we're already there, really start pulling those things back. But if you start to notice those as new behaviors, something to really check in on.
Kind of scared because you're kind of describing me.
Well, this is I think the other myth part that's maybe not so much the myths or misconceptions about eating disorders, but some of the myths and misconceptions about things that get thrown out there as normal or healthy or wellness behaviors for all of us.
Do you know what muscle dysmorphia is?
Yeah.
Can you explain it real quick for the viewers?
It's in some ways some kind of, so it's not a diagnostic criteria yet, that we would generally put this under more of a body dysmorphic disorder if it was the perception of the body alone and not kind of changing kind of eating and training and that kind of stuff. But it's really sort of saying almost the opposite, that we often think of someone experiencing something like anorexia, of thinking, oh, I'm always too big. When we're looking at this in terms of kind of training and muscle dysphoria, often it's like, I'm not big enough, or this shape isn't right, and real preoccupation about there's something wrong with the overall size, shape of my body, or specific attributes that other people are saying, like, I truly don't see it the way you see it.
That's crazy. Like, what are the long-term consequences that people can have from eating disorders, like, or untreated or poorly managed?
They stick around. And I think, if anyone listening has kids, teenagers in their lives, personally or professionally, the quicker we get in and the quicker we identify what's going on and get some movement on that, the better off that young person is, both for their physical and mental health long term. Early intervention is important. That's true of adults as well. Like if you were 30 and this stuff reared its head, getting in there quickly saves a lot of collateral damage. Untreated, what we know with eating disorders is they don't tend to just go away. They may move from kind of category to category, but depending on what people's symptom profile looks like, we're looking at things like, just poor cognitive functioning, if there's a lot of more dietary restriction and starvation. So that's kind of a short to medium, or as long as it's going on. There are also a lot of concerns around bone density, osteoporosis, if people are using purging behaviors. Sometimes that's even problems with enamel, esophageal cancers, mouth cancers show up for people, issues with electrolyte imbalances, cardiac risk, stroke. Suicide rates are much higher in folks with eating disorders than the general public or people with more general mental health concerns. And I think that's one thing that really, really does, I think, need to shift and need a lot more attention. And when we think about myths and things and consequences, eating disorders are the second most lethal psychiatric diagnosis. And it's not that eating disorders got kind of safer. It's that the opioid crisis hit. So we're saying, okay, kind of second to something that has been its own epidemic.
Yeah, it's a hard one to beat.
Yeah, and I think for anyone working kind of in the field, it's like, we would really love to notch it down and think like, well, this is getting kind of safer because we do have, if there were better, more efficient, or improved access to care, that it wouldn't sort of have this collateral damage and health consequences and death toll associated with it.
How can you support someone, let's say like your partner or your son or whatever, like how can you support someone with an eating disorder?
I think step one is also like check what is going on for you about your own reactions to this. And I think especially with parents, sometimes they'll
Overreact?
I would say actually kind of more maybe overreact or react internally and sometimes kind of underreact. Families, moms specifically, in the history of mental health have had a really bad rep. And I think a lot of people go, well, if I'm bringing this up to my kid's doctor, or if I'm bringing them in to see someone, like, does that mean I've somehow failed them? I've done a bad job? And it's not. I think for anyone understanding really how eating disorders work and working with that now, families can be families, whether that's for kids and adolescents or for adults, right? People's support system can be a really, really strong ally in recovery. Sometimes that means saying, okay, well, what does your own dieting behavior look like? I've worked with a lot of folks who've said, like, yeah, like parents will come into session, we do a lot of education, they're on board for what's going on for me, and they're doing all of the things we've asked. And then one or both of them are going like, okay, well, you're going to eat that, and I'm, insert diet name here. where the person who's trying to do all the recovery behaviors might be saying, well, this is sending me a really mixed message. It's also giving the eating disorder a lot to thrive on. And when it comes to separating kind of your loved one from the disorder, I think that's also really, really important. And I'll often have chats with clients of, I'm not really that interested in being super popular with your eating disorder. And many of them will go, good, because you're not. It's not where I'm aiming to be. So if we're saying like, in terms of supporting people, can I be aware of my own stuff that I might be bringing to the table? Can I really be kind of consistent? Can I be open to educating myself? And if your loved one is working with a professional, to maybe be, whether with your loved one or if it's okay with them, kind of offline getting some education, super important, because you could have, like we talked about before, you could have a whole bunch of people with the same diagnosis who might have different stages of readiness or might have different treatment targets that would be followed through at home. So, I think it does really help us to get our clients the best help they can get at home by saying, let's fill people in. Mom, dad, partners, friends, it is not your job to be your loved one's therapist or your loved one's dietitian, right? If my partner had an eating disorder, I wouldn't be the one treating him. And that's my job.
Wow.
So for us to say, okay, we can create that boundary. We can also create some distance between what's going on with the eating disorder and this person that I love, and taking care of yourself. Right? It's sort of that idea of like when we're on the airplane, even if you're traveling with people you love, even if you're traveling with people who are in a vulnerable state, you put your mask on first. I think it's important too to be thinking sometimes, especially, sometimes in terms of my work with teenagers, parents will come in and say, I know I'm really worried. I really need you to see somebody. And that person's saying, I have no interest in this. I'm not doing it now. Okay. They may not be in a place where they're wanting to or open to treatment. My suggestion then is usually to parents and families to get your own supports, whether that's kind of parent coaching or just a place where you get to go in and talk about how you're feeling about what's going on, because there's going to be a lot of fear and there's going to be big feelings.
Yeah, and you can't help anybody who doesn't want help. That's that's a lot. Like a lot of well, I don't want to make correlation to drug addiction, but you can, in a certain way. Like if they don't want to help their addiction themselves, you can't do very much.
And there are some pretty strong parallels between addictions work and eating disorder work. And I can't for the life of me ever remember where it comes from, but it's a writer who's kind of writing about eating disorder recovery was saying, like, if in an addiction kind of framework, if people are following an abstinence framework, they kind of sometimes talk about kind of caging that tiger. And, the intent of the piece was not to sort of take anything away from how hard that work is for folks with addictions. Yeah. The person's point was also for saying, well, that's not an option someone has when it comes to their eating behaviors. So it's kind of saying, how do I be able to cage that tiger in terms of modify some of these symptoms, but also develop this relationship where I feel safe taking that tiger for a walk a few times a day. And that's a really different paradigm.
Taming the tiger.
Yeah, like I somehow need to come to peace and to actually develop a new, healthier relationship.
What are the effective treatment options?
In terms of evidence-based treatments, cognitive behavioral treatment, so enhanced cognitive behavioral treatment for eating disorders, is sort of by the research our gold standard. Caveat to what I'm going to say next, I do not mean this in a demoralizing way.
No worries.
But what we know is it works for about 45% of people. It is really, really normal for folks with eating disorders, especially if they've been with the person for a while, to not have everything remit after that first course of treatment, that they may need several courses of treatment and they may need different things. And I think that's really important because, as much as clinicians, we think, okay, evidence-based treatment, we are research nerds, we want to know we're doing right by our clients by actually kind of working in a way that should work for them. We also have to notice that gap of saying, well, and when this doesn't work, what are our backups? So there are a lot of other treatments, acceptance and commitment therapy, dialectical behavior therapy, sometimes motivational interviewing are parts of things that we do. I tend to work more from an integrated approach, and I always have my dissertation supervisor's words in my head when I remember applying for internship, and it's this whole huge process. And they
Yeah.
say, okay, take off, like, what are your therapeutic orientations? I'm like, integrated versus eclectic. I was like, what's the difference? He's like, don't hit eclectic. That means you're just doing things. Like, if you are integrating what you're doing, we may say, we're going to pull from this cognitive behavioral piece because we need this for a certain stage of treatment. But someone else might need more sort of like emotion regulation skills that would come from an approach like dialectical behavior therapy. Somebody else might need more of a trauma-informed intervention. So what becomes quite complex really quickly is, again, that idea of like same diagnosis, very, very different treatment need. Whether that's because of people's, the whole background story, or just what fits for them.
Are there any advancements or like promising approaches in the field?
Yeah, so some pretty cool stuff. I mean, even from the psychotherapy approach, I think something that I'm really liking, especially with working with folks who have a more sort of like an emotional over control that we often see in presentations like anorexia, is the radically open dialectical behavior therapy kind of variant that they're developing, which is really around, okay, how do we actually get more access to these feelings? How do we actually get you, improving sort of sense of social connectedness and social cues, because that's a big one. But also there's some other pretty cool biological stuff going on around like the RTMS treatments, which are essentially kind of magnetic cranial stimulation that are non-invasive. I've known several people who have done them either in Toronto or here in the Ottawa-Gatineau area who's kind of said like, yeah, it's sort of like going to an orthodontist appointment. I drive myself there. I'm fine. It's there's been a lot of work from the RTMS kind of side around treating depression, trauma, and eating disorders as well, in more, I guess, invasive. So what would be reserved for quite kind of severe presentations, some deep brain stimulation work that's being done as well.
So in layman terms, they're trying to reassess the brain waves in your head, pretty much.
Yeah. And looking at like, that these are not, an eating disorder is not an extreme diet. It is not a lifestyle choice. It's not something that someone is choosing. We are knowing more and more, and the more we learn about the brain is that like there are really strong genetic and neurological pieces at play here. And I think to some degree with some of the psychedelic assisted psychotherapy or psychedelic medications that they have been finding promising results with things like PTSD and depression, that it'll be interesting to see like where that goes and how that research is applied to other mental health conditions.
Wow. Have they started to do that yet or no?
I think here and there, but there haven't been any like big published trials. So that is a caveat to say like we don't have like a solid research base saying this is something that's going to be helpful for folks. There's also a big difference between doing a psychedelic assisted psychotherapy or something that is prescribed and like really managed from a psychopharmacological side, then hey, how about mushrooms at the shops that are picking up?
That's exactly what I was going to say. It's true. Yes. Okay. And there's a difference between going out in the woods with your buddies than and having a clinical environment and actually doing it for a specific reason.
And we can apply that to a lot of things. Like I'm forever cracking my own teeth when I see things like running's my therapy. We might say, okay, like you might get a lot out of this. There may be a really kind of helpful factor here. You might offload stress, do all sorts of things. Great. Do those things. Yeah. If out in the woods with your buddies and whatever is going on is like you come back going like, I feel connected, I feel refreshed, great. And when we're talking about folks being in a range where something is really distressing, really stuck and getting in the way of their health and functioning, generally we're saying, well, working with a professional that, sometimes it's easier said than done or easier said than is actually accessible is quite different than, other kind of maybe health promotion or kind of self-care or wellness things that people are doing on their own. It's not to take anything away from those activities, but the active therapy is going to be pretty different.
Let's talk about mental health and relationships. Look, of course, mental health can significantly impact relationships, but what are the common challenges that couples and families face in terms of dealing with mental health issues?
Sometimes it's that some of those factors that led to, that kind of identified person or persons struggling with what they're struggling with may be impacting everybody to a certain degree, right? If we're saying, if we know that some of the big factors around mental health generally, that there is a strong genetic component, like across disorders,
Yep.
Right? Like if I say, I have, coming in with depression, we may say, family-wise, like anybody else had similar issues with anxiety and depression. It's good for us to know. But also that, like you said, mental health can impact relationships. Relationships also impact mental health.
Of course.
For better or worse.
Absolutely.
So in a lot of ways, especially if we're thinking in kind of families, we all have a lot of history and a lot of time with our families. No one's kind of coming in as the just observer to this. Everybody's swimming in a lot of the same stuff and a lot of the same history. The other part is, unlike seeing a professional who, I don't think any of us who do this kind of work and love our jobs would say we don't care about our clients. We absolutely do.
Yeah.
And it's in a different way or different capacity where we're able to kind of stay sort of more connected with them, but objective, versus, and speaking on behalf of therapists, psychologists, we don't show up at home in the same way for the people in our personal lives that we do in the office. I had one of my adolescent clients not too long ago say oh, it must be just super helpful to have a psychologist at home. I'm like, could you write that down for me? Maybe sometimes.
Yeah.
And other times it might be something that's, your vision of maybe how Dr. G shows up at home is different than when I'm rolling through the door, exhausted, talked out.
Of course.
Just in a more kind of unfiltered brain is off. Just human way.
Yeah.
So when we're saying in our families, we also with people we know very well and have a lot of experience with, we put a lot of maybe kind of assumptions on what is going on with them. Well, I know them so well, so maybe we don't ask the same kind of questions as we would with someone that we don't know as well. We go well, no, I know when they're like this, it means this.
But do you though?
Exactly.
Yeah.
Or, I see them as having a lot of similarities as me. So when I'm like that, I need this. Okay, but do they? Sometimes that means we go on a lot of knowledge about someone or a lot of history with someone and don't ask the questions. The other part is sometimes we go ahead in our own emotional systems and brains kind of go up, our own walls might go up, or we might go well, this is somehow either about me or a reflection of me. And I mean, sometimes we see people start to have challenges with mental health because something's truly not healthy in a relationship. Or we might go well, this may or may not be about you, or this may be about, in a dynamic way, how things are going between the two of you. But how do we step outside of that?
How do you navigate these problems? Problems, air quote.
Well, sometimes that's looking at, if I'm working with someone individually, sometimes that is making a recommendation for them to, see a couple or a family therapist with their loved ones. So we can say, hey, we can be doing your recovery work here just for you, but also that this really important aspect of your life is also getting some attention.
Let's talk about adolescents. Look, adolescents. I work with adolescents as well, so I know what you're going through. It's a critical period for mental health.
I love them.
I know, me too. I really do. I really do. And but what are the most prevalent mental health issues you see in young adults?
Well, especially the pandemic was not kind to
anybody,
our younger friends.
Yeah.
And a lot of times to be thinking, well, if we can all think back to what was it like to be in that adolescent period, us being popped out of school, being at home, not being able to see people, that would have a much more profound effect than us as adults saying, okay, well, you're not going to see your friends as much. You're going to be working from home. Well, in some ways, right? Some adults were going whew,
thank God.
okay.
Yeah.
And I will also say that I had some of the adolescents that I work with who, had some really rough contexts at school, or whose really bad things like social anxiety was getting in the way of them being able to get to school that was impacting their grades. They actually went bring on like homeschool and letting me say, and their grades went up and all of these things. We're saying, okay, because this took away the anxiety.
They
right?
have their safe place, yeah.
But overall, when working with people in an adolescent period, their big developmental job is, who am I outside of my family?
Ooh, that's a good one.
Which means, right, kind of pushing back from mom and dad. Often parents are kind of going like, I don't know, they don't want to spend any time with us, so they're always kind of contrary about doing it, or like they seem to be so focused on their friends. It's like, well, yeah.
Yeah. They're trying to find an identity. You know?
And there is sort of this period in adolescence and sort of young adulthood, often for people, kind of a bit of distancing before coming back with family, because we're saying, I'm really trying to figure out, who am I in my peer group? How do I navigate relationships that aren't family relationships? And so then we popped all those people kind of out of their clubs, their sports, hanging out with their friends, being at school. We also, for kids who have, maybe less than optimal home environments, popped them out of teachers, coaches, other caring adults, which is really precarious. So we have seen rates across the pandemic and now of things like depression, mood disorders, anxiety be much, much higher.
Wow.
And, we can, like, locally, there was a lot in the news about kind of our children's hospital in Ottawa seeing really, really, like, steep admission rates. And I think at one point, I mean, they are a child and adolescent facility, but they're also a general hospital. And when they looked at rates of admissions, their rates of more mental health admissions were much, much higher overall for the hospital compared to physical health. They were also finding kids coming in like more distress at more severe kind of presentations, and then sometimes with more kind of related medical stuff going on.
Oh my God, the social aspect of the pandemic was really, it was brutal. We're still seeing the results from it, which is crazy.
And I think a wild thing, especially with some people that I work with who are now kind of in that sort of like kind of end of high school and or just starting university, where they're going like, okay, now I'm popped into this, but for 27 years, 3 years, 2 months, however long we were doing it, they went like, I didn't have any of the normal gear up to this stuff. So you think of, okay, what's your communication like around friendships, dating, sexual relationships? It's kind of like we said, we took y'all at a practice, and those times when maybe like none of us knew what was going on. So to say like, okay, you're good to start entering into this now that you're 20. People go like, I don't know what to do.
Yeah. Yeah.
And I think that's always held true for, if kids have had major physical or mental health concerns. Like we see this a lot with kids who've had a lot of hospitalizations as kids or as teenagers who weren't in kind of a typical school environment. They're kind of playing catch up once they're in a more recovered space as young adults. And we're saying like, hey, like from the adult side of things, especially sometimes for me, I'm going like, as the adult person who and who's not your parent, like none of us knew what to do. If you're looking around at same age peers and saying, well, they seem to know, it's like, well, yeah, because when you were doing this really important work to recover and be alive now, they were doing things on dates that didn't work out very well and bumbling through, and we were all just like out there making asses of ourselves and learned what to do and not to do.
Live and learn.
Yeah.
How can parents and educators like play a role in promoting positive mental health outcomes for young people?
Listen. I think in some ways to talk less, ask open-ended questions, and try to be okay with hearing some things
that you don't want to hear,
that might freak you out a little bit. If you're worried about something and you have a trusting relationship with a young person in your life, in a way that's private, that's not putting them on the spot, ask about that. And a lot of times parents will say, well, I didn't want to bring it up. I didn't want to put an idea in their head. And the truth is, if asking about depression, eating disorders, even suicidal thoughts was the problem, my job would look a lot different. We have pretty frank conversations about those things.
Yeah, you have to. You can't beat around the bush because Their thoughts are pretty concrete.
And I think when it comes to schools, I mean, I would say, if I had a kid who came home saying like, hey, they weighed me at school and I'm going to be doing this food log and stuff, there would very quickly be a note coming back saying like, we will not be as a household participating in this. Like, those are just things that do not need to happen. And I think really when it comes to, I don't know about you, I thinking back to kind of, even like health and kind of like health class nutrition stuff, we learned like the food guide, which has been...
Its flaws.
Well, it has been revamped, right? It's no longer kind of that pyramid. And I think if we're saying, well, is the Canada Food Guide perfect as is? No, but this is actually the first iteration that didn't have kind of lobby groups and stuff in the room. So it's a lot closer to actually being like vetted by and coming from kind of more like medical and dietetic professionals.
Really? So the old version was just a bunch of lobbyists pretty much putting together a pyramid?
Apparently, there were some groups that were very angry to be left out. And it's, hey, from a business perspective, I get it. From a health perspective, deal with it.
Yeah, get with the times. Wow.
And so those kinds of things. I mean, I have a good friend who's a high school teacher in Toronto, and she and I have had a lot of mental health talks. She's a big mental health advocate for the students she works with. Yeah. And she's like, hey, I need to talk to you about, I need to run some things by you about this body and nutrition kind of module in the biology class I'm teaching. Like, put your ED hat on. Like, what do you think about these things? Like, how can I talk about this? Because she, even in looking at that, was like, for a lot of people in the room, it might be totally benign and fine. However, if we know that, that even though we know eating disorders don't discriminate, you don't have to be a teenage girl to have one. Many, many people who do don't fit that demographic. Yep. We also know that that's one of the biggest kind of times when an eating disorder will emerge, and that adolescent females do comprise, a big portion of folks that we see with eating disorders. So her point of view was very much like, I don't know the health history or current kind of status of every kid in my classroom. And I want to make sure this isn't reinforcing or triggering something that's going to be problematic or damaging or dangerous to one of my kids.
In your experience, what are the effective therapeutic approaches or techniques to support individuals with mental health, or adolescents, with mental health?
It really depends.
Okay.
I would say with the adolescent population, a big part is our relationship building with them.
Okay.
We know our therapeutic relationships and that working alliance to be true of effective psychotherapy for people generally. But if we go back to that idea of our adolescent brains are all looking at and are all kind of preoccupied with, where do I fit? How do people see me? And if we go back to our adolescent selves, that idea of are people putting too much pressure on me? Or are people seeing me as kind of like a dumb kid who doesn't know? And the really tricky part, and as adults, we do not mean to do this to adolescents, but we can say, hey, I'm having this very adult conversation with you, so I'm having these expectations based on that, and then their brain glitches. And we go back to the kind of child brain side of things, and it's saying, well, yeah, if we're saying full kind of brain development, and especially the executive functioning, all the planning, decision-making stuff, for that to be fully cooked, we're looking at kind of more 25 to 27 years of age before we're done.
Really?
Yeah. So
are we having it too young, you think? Or what would be the cutoff age to have those conversations?
I think they have to keep going, and they just have to be, they have to be developmentally kind of appropriate to what your kid is doing. But sometimes where we say working with adolescents, saying I'm not judging for that, right? That happens when we're in those developmental kind of transitions. We're kind of a foot in both. So having a more kind of for lack of a better word, kind of kid-like reaction to something doesn't mean someone doesn't know what they need or doesn't know kind of how to take care of themselves. It means that's exactly what their brain should be doing right now.
I want to go back to, I forgot to hit body dysmorphia. I had a crazy childhood. I was severely obese, and I lost a lot of weight growing up. I had a lot of problems with body images and stuff, and body image concerns, like, they have a significant impact on self-esteem, mental health. Like, what are some practical steps you can give individuals so they can improve their body image or develop a healthier relationship with their physical appearance?
Yeah, and I would even say kind of just a better relationship kind of with our bodies. So
Yeah.
first of all, it's great that you're sharing like what your experience was
Oh,
and
it's
saying
terrible.
like, well, and I think to be able to say like, this shows up for people, right? The idea of body image disturbances, whether that's going through a rough kind of patch or a rough day or a rough moment, it's like none of us are immune to this. And well, why is that? Because we live in a very weight-centric, weight-biased, and diet-centric culture, right? Of this idea that my body is a thing for me to control, is supposed to look a certain way. And in terms of bullying, discrimination, all sorts of stuff, that often folks who are in larger bodies or at larger sizes, they're saying, hey, this isn't like my perception of myself. I'm actually incurring a lot of like really shitty treatment. This is a problem I am facing in my life that makes me feel really bad. And I think in that case, for us to be able to say like, can we work at doing a bit of that kind of grief work? I mean, especially if we're going like, hey, as an adult, I remember this. Yeah, there's probably some grief that goes along with that, right? Anybody who experienced that is going like, yeah, there were some things that like I needed that I didn't get, or I needed my environment to be different. And to really be able to say like, whenever it is kind of that relationship to my body or my body image is how I'm feeling about myself and how I'm perceiving my body. That body image problems are not a problem with our body. It's the cognitions and kind of emotions that we're experiencing that go along with it. So first step is to sort of say, this is not my body's fault. If I'm having a bad body image kind of day, or I'm really struggling with this now, the answer is not to take this out on my body. My body is part of me. It's like, that's going to be sort of that ride or die relationship we have beyond anything else.
But sometimes just that they're realizing like, I'm stuck in this body. For me, that was a lot. Like, oh my God, like I'm going to be like this for the rest of my life. But then I realized like, okay, well, I can actually do something to change it. And then when I saw the changes, I was like, okay, wow, I'm not going to stop. But now it doesn't stop. It never did.
Yeah.
So every time I look at myself in the mirror or whatever, it's just like, oh my God, it's not enough. It's still not enough. It's still not enough. So like, it just, I don't know. How do I get rid of that? This is my show now. Okay.
Well, and so I think that oftentimes folks, say experiencing like an eating disorder that's really kind of preoccupied with shrinking and weight loss would experience something similar, right? Like, well, when I hit this number on the scale, then I'm going to feel better.
It's not about the number.
No, but that's a really great eating disorder lie. Well, there's a certain body, there's a composition, there's an aesthetic where you'd be totally satisfied. That there's some aesthetic or archetype of a person who never is hard on their body and doesn't have body image concerns. And that's just not true, right? There are people who aren't preoccupied with body image concerns, and those people may look all kinds of ways. So for us to be saying like, well, one is to recognize that this loop I've got going on in my head just keeps kicking that bar farther and farther down the line, right? I'm in this kind of like losing hamster wheel where no matter what I do and how hard I work, it either goes, good job, you've come this far. What about the next thing? When it's being kind of like benevolent, or when it's being more critical of like, that's it? You want me to be happy with this? What about that? He looks this way. She's lost this much. Neither work, right? Because we're saying like legitimately, no matter what I do, no matter how I change, this more kind of cognitive loop in my head is just going to change the rules.
It comes back to self-care. Self-care it's often emphasized like as an important like aspect of maintaining mental health. And honestly, to me, that's what helps me the most is self-care, taking care of yourself. It could be physically, it could be mentally, it could be, you know, from the food you eat. Like,
And you said something really important
Yeah.
of like, oh, this is my body I'm stuck in. Well, if we think, hey, I'm in a partnership here with my body, and look at all the things that it does for me on a daily basis that it's been able to do, right? All of those times, that moment of stress, no matter how crappy I was feeling, my body did some pretty cool things, maybe around emotion regulation, helped me find a coping way, right? Whether that might not be something that I want as my sort of like one tool in the kit,
Yeah.
but my body and my brain figured out how to get us through. And if we can change from, this is my body I'm stuck with and I need to control it, to like, this is my body, it is mine, from an acceptance standpoint of like, this is my body right now. Okay. It's my home. We're going to be together hopefully for a long time. That's the idea. That's when things are going well. There are going to be times when I'm happy with it, when it's happy with me, and times that when we're kind of at odds. But can I show up, and even times when I don't maybe necessarily kind of like my body or I'm not happy with it, can I act from a space of respect? Your lovely girlfriend is here today, so I know you're in a relationship.
Yep.
As a couples therapist and longtime married person, where we can say, are we always happy with our partners? I'm going to go out on a limb here and say at our house, no. Speaking on behalf of my partner,
Yeah.
he's cheering in the background. But if we want a relationship to be healthy, if we want to grow, if we want that to endure, we can say, hey, I might be really angry with you right now. I might not be really happy. I might not want to engage, but can I show up in a way that is respectful of the other person, as opposed to like guns blaring, I'm angry with you, so I'm going to rip you down. That doesn't work. And I think when we look at that from that relationship frame, this is the relationship I'm having with my body. I may not like her right now. We might kind of really be at odds, right? She's doing one thing for my survival. I'm holding another idea in my head. Okay, can we kind of like put the guns down and say, I will approach you from a place of respect.
Has to be your peace, and has to be your when you come home, it has to be your place of support, your place of peace, like a place where you can go and talk about whatever, where there's no judgment, or because I've had negative relationships where our emotions were just all over the place. Like, one, you have to talk about your emotions, and number two is to be open, like to whatever she is going to say or he is going to say. You have to be open to it. If you're not open, it's going to be so hard to communicate. And communication is key. If you have no communication, your relationship will not last.
Yeah, I think it's Chris Rock who has that joke about like, it's pretty easy to move a sofa with two people, but like damn near impossible to do it by yourself.
Yeah.
And like that model of relationships of saying, yeah, if we want something to be healthy, if we want change in our relationship. And I think even that applies to our relationship with our body, right? If I say, hey, I want my body to start being better with telling me like hunger cues or kind of recovering from like a physical injury or something. Well, I can't say, hey, body, like carry that sofa alone. I need to also be saying I am mentally and behaviorally showing up and also giving you what you need. And when you said like, if our relationships are these places we come home to, moving that over to our relationship with ourselves, like our body is truly what we come home to. And a lot of times folks with eating disorders, with chronic health conditions, with trauma histories, especially if that's been body-based, have a really, really hard time feeling at home and connected with their bodies. And that's part of the work that we do around saying like, we want to get you reacquainted, both with your physical self, your emotional self, or that idea of like, you said, talk about my feelings. Even sometimes internally, I have to be okay. First acknowledging I am a person with feelings. They're all okay. There's not good feelings and bad feelings. Some are more comfortable than others. Some of us have different rules about which ones are good ones and bad ones. But that it's all information from our system about what we need more of, less of, and what's working for us.
Our complicated system.
We're messy.
Yeah, we are.
It's part of our charm.
A soup of emotions.
And it's also it's part of our human condition that we're we're complicated, we're messy.
What self-care practices or like strategies do you recommend? Well, not only to clients, but like for people listening, dealing with emotional eating, body image issues, relationship challenges. Like, do you have any practices?
Yeah, in terms of self-care,
Yeah.
for, especially for anyone who's dealing with kind of binging or more kind of restrictive stuff, the first would be to nourish your body, right? That idea of we can't sort of self-care our way out of situations where our basic needs aren't being met. So if we're saying like those, really looking at what are those kind of core, if anyone's taken like an intro to psychology class, maybe you've seen it, like Maslow's hierarchy of needs kind of triangle. Right there at the bottom, do we have adequate kind of like food, water, safe shelter, are those things that tell our nervous system, okay, you can relax. Like, our basic needs are met. We might have other work to do on our situations, but we can't start doing any of the other stuff without those really basic building blocks. The other part is saying like making more time for yourself. So often I see folks with a lot of, discomfort being in their own bodies or their own emotions, staying so busy that it's like, I'm almost trying to like outrun my experience. Can we make space for that? It might feel scary. It might feel threatening. It might feel like a stupid thing to do initially. But a lot of the times that idea of like it's stupid to do is like, oh, I'm actually kind of freaked out about what might come up. There's nothing you're holding that you don't know. And carrying it around is taking a lot of your energy. So making some of those practices of journaling, of booking a therapy appointment, of talking to yourself out loud, right? Like, not something I'd suggest maybe on like public transit and things that might look a bit off, or you might be sharing personal things with people you don't know.
Yeah.
But how do we get these things out of our head? Because they spin around. I think my favorite kind of self-care definition is like building that life that you don't need to escape from regularly. So that it's not just, well, I'm running myself ragged, I'm not taking care of my health, but, I did a face mask. Okay. No disrespect to face masks, great. But sometimes we also need sort of more in-depth sort of self-care about simply saying no. Boundaries are self-care. Attending to our health is self-care.
Well, Doctor, thank you for coming on.
You're very welcome.
That was awesome. Where can people reach you?
I am on Instagram at Dr. Meagan Gallagher.
Awesome.
And our practice website is integratedottawa.ca.
Cool. Guys, go check her out. Like, subscribe, share, and I will see you next week. Tell a friend to tell a friend. Peace.